If you've ever wondered, do I need screws for this osteotomy or that osteotomy? This video is for you. I was trained in the Dr. Reverdin Isham tradition. I've performed 1500 plus MIS cases, run 40 plus small group private cadaver labs, and I've hosted the International MIS conference at the OLC 8 times. In the next 10 minutes or so, I'll answer the questions surgeons keep asking me. Gear, fluoroscopy, fixation, office-based surgery safety, and give you a simple next step. First question, is MIS legit or still fringe? Short answer, legit. For mild to moderate hallux valgus, MIS is recognized when indication and technique are sound. The 2024 AOFAS position statement on MIS HV lays out the landscape. So minimally invasive isn't just a logo, it's a discipline and it's approved and it's legit. Second question, MIS versus open procedures. Do patients actually do as well? So several studies say yes when done properly. A 2022 Frontiers in Surgery meta-analysis favored MIS on radiographic and clinical outcomes. A 2023 meta-analysis was more conservative, and 2024 Living Systemic Review suggested newer generation MIS can be superior for certain measures. So bottom line, with discipline, technique, and selection, outcomes are comparable or better. I'll link all three in the description. Question number 3, do I need internal hardware fixation for MIS forefoot osteotomies? Not always. In classic Reverdin Isham bunion correction, stability comes from osteotomy geometry and discipline dressing, so no screws. For lesser mets, DMMO is designed as a no fixation approach with controlled settling via functional bandaging. I'll still use hardware if a case truly demands it, but in my hands and in the Isham lineage, fixation is unnecessary in many cases. I'll link a 2024 systemic review on Reverdin Isham, a 2016 prospective JOSR study, a 2018 with versus without fixation series, and the standard DMMO papers. Question number 4, do I really need fluoro? Well, soft tissue tenotomy or capsulotomy, you're fine without it. The moment you touch bone, use a mini C-arm. Safety beats bravado. Learning curve papers show fluoro use and time normalize with reps. Well, studies will be in the pinned resources. 5th, what's the starter gear without buying the whole store? So keep it lean. Actually, I'm going to go over to my training lab and then I'll show you quickly overview of those instrumentation and MIS drill set. Sounds good? I'll see you over there.
Really use 4 of them. You know, this is how simple the minimally invasive surgery can be for foot and ankle surgery. Beaver blade handle typically holds my MIS blades, you know, like 64, 67, pretty much, and 62. Like 3 blades, that's what I use. And this is mini elevator to, after make a portal, to create, you know, nice portal, like release capsule around the bone where I'm going to make a bone cut. And then this is mini rasp. So, you know, I kind of roughen the kind of shiny, slippery cortical bone area before I apply to bone cut, like hammer toe, same deal. We make a portal and then, you know, just kind of grind them, the initial area, so that rotating burr, which cuts bone and creating osteotomy, it doesn't slip away. This is bigger, typical bone rasp. If I do bunion, let's say, and then, you know, kind of grind them down in a sharp corner or something like that, or I can flip it and then I can remove some loose bone paste and stuff, you know, through the portal. Imagine there's skin here, right? So really, that's it. Well, this is called Osada. Unfortunately, they right now discontinued making it, so you might be able to find Osada drill set, tried and true, right? Most MIS surgeons still use this. So on and off, forward and reverse, and then basically side control, and then you can see most important thing, guys, is the develop sensation and cutting bone with the lowest speed as possible, because this instrumentation has high torque. So you don't need to speed like that. You're gonna burn bones and soft tissue, and you're gonna create a lot of damage and soft tissue swelling and wound dehiscence. Most doctors I teach don't go over more than half. So this is enough to control, because this has very strong torque, and you can cut it with just about this much speed. Again, details you should learn in the cadaver lab setup. This one is one of my go-to now. It's developed by a Korean manufacturer called Fixation. They got different model. This is cheaper one, lower model. They have a higher line too. But I just want to demonstrate, this is the foot switch. You can adjust different RPM. I can remove handpiece, and there's multiple handpiece available. Some of them are like only $50. Some of them, this is Korean made. This, I think, around, still very inexpensive, like 150 or something like that. And then this is German made. And foot pedal, again, see how quiet it is? I don't know if you can hear it. You don't need to speed too high. That's the most important part in MIS procedure. Anyway, I just gave you a quick tour, because this is like some of the most commonly asked questions to me. In the background, you can see this is our MIS training lab I created last year, because I've done 38 private cadaver labs to help foot and ankle surgeons with minimally invasive surgery in the past, since 2017, so right now, past 8 years. I've done 5 advanced MIS labs and then 8 international MIFAS cadaver lab conference. So, I have experience in teaching doctors. If you are interested in going deeper and learn MIS the right way, click this side or this side. You'll see a link. You can explore more about MIS intensive program I developed, so that you can see different levels and how you can achieve those with the right technique, right structure. So every procedure I perform, and I help doctors and I teach other doctors perform, they're proven and evidence-based. I have collected over 200 articles and studies. Just leave me a comment or send me a direct message. If you want proof, I can show it to you. We can connect. Again, I just wanted to show you a quick tour of our training lab, how we set up minimally invasive surgery, and then I briefly showed you office-based surgical.
Number 6, hammer toe. Does percutaneous procedure hold up versus open procedure? Recent comparative work shows similar union, return to activity, and complication ranges when technique and aftercare are dialed. I'll link a 2024 JFAS comparative study. Number 7, interdigital corns and lateral fifth toe pain. Does percutaneous bony work actually help? Yes, for the right patient. Prospective and case series data show good relief with low complications when you keep the contour discipline. I'll link the 2021 cohort study and 2022 foot and ankle orthopedic series in the description below. Number 8, office-based surgery, safe or sketchy? Well, it's safe when protocol-driven documentations, checklists, and logs and sterilization flow, they're aligned. A 2024 JAMA office study reported around 2% superficial infection rate, comparable to or lower than many outpatient foot and ankle reports. I will include both for context so you can see the numbers. Number 9, the learning curve. How many reps until you feel safe to perform MIS? Well, it's not years. It's sequence and repetition and right system. So systemic reviews put the plateau somewhere around a few dozen cases for MIS hallux valgus, with more fluoro and time early, but no clear spike in complications. My 60-day ramp is simple. 2 supervised reps, a structured case planning call, then a quick debrief loop in our MIS Elite community membership. Number 10, which 3 procedures should you start with now? Well, number 1, soft tissue. extensor tenotomy and capsulotomy. No fluoro really needed, fast wins. Number 2, lesser digit bony work, digital exostectomy and percutaneous hammer toe work. Mini C-arm is definitely recommended. Number 3, lesser metatarsals, such as Taylor's bunion or lesser metatarsal DMMO style osteotomies. The classic non-fixation pathway with proper selection and dressing. I'll add the DMMO technique resources below. Well, I want to tell you 2 traps to avoid while you learn MIS. So I call this MIS hijack, which is the hardware first gimmicks pretending to be minimally invasive. And the second one, I call it the cadaver lab conga line. So it's like 4 to 8 surgeons to one cadaver leg specimen, and nobody builds tactile sensations and other sensations you really need to develop true MIS skills. So anyways, if you want this to stick, it becomes your skill set, you need real reps with your own hands-on experience, the right sequence, and actual feedback from proper mentorship. If you have questions around gear, fluoro, angles, or OBS policies, or anything around the MIS, please drop a comment. I actually answer. If you want a hands-on rep, we run a private MIS cadaver lab in Glenview, Illinois. So it's a tiny group capped at 12, 1 cadaver per surgeon, up to 10 CE hours, 3 to 4 times a year. It's designed to install skill, not sizzle. The link is in the description and in the pinned comment again. Okay guys, if this was helpful, hit like so more surgeons find it, and subscribe for more on MIS foot and ankle or practice growth, AI in healthcare, and medical marketing for cash pay success. I appreciate you being here. I'll see you in the next video.